And now I come back to computer-assisted surgery. I'm sorry because I will do some repetition, and we assist to a so perfect presentation from Professor Allen, and I don't know if I'm at the level for discussing about it, but I try to do. So, what is computer-assisted surgery? Surgical technique that use in some way computers, and this includes preoperative planning and intraoperative guided surgery. So preoperative, we have imaging, X-ray, CT, MRI, as you need. In orthopedic surgery, preoperative planning is mandatory. We spend most of the time, more time in planning than less time in surgery. So it's time consuming, but it's really, really important. And we take some measures and we plan specific cut. We'll discuss also about intraoperative guides, different type of guides. So I start from the basic planning, because this is a computer assisted vicino?
Sì, è stato un po' vedere che si strutturasse sconfitto.
Ok, ma io sono indisciplinato. Ormai a una certa età. This is a preoperative planning at the computer. It's a standard planning, but today is normal, but 20 years ago was not normal. 20 years ago was the future, okay? Now we plan a TPLO, a basic surgery for orthopedics, and we plan the cut, we plan the measures, we plan the plates, different size, different model, and we can do everything on our PC. We plan implant size. This is a plan for total hip replacement. We do it every day. We plan for bone deformity correction. This is a plan on X-rays, but we can do also a plan on a CT scan. We plan, and we want to do the same during the surgery. Now, I speak about a little bit around this 3D printed guide, because I don't love this system, but it's necessary to discuss. You can acquire by CT scan a bone model, a virtual bone model of a bone. You can, with a deformity, you can study your deformity, you can create a correction, and you can create a virtual guide to obtain specific cut. You can print your guide in plastic, your plastic guide. You can sterilize the guide. You can go in surgery after 1 month at least. And you can create a specific cut and a specific correction. I don't love it for different aspects, and if you want, we can discuss later. It's time consuming, and most of the times these guides are not so perfect on the bone. At the end, I think that could be the future, or we are working for the future. We can have this system, intraoperative surgical navigation. I try to illustrate what is, starting from the basis. Surgical navigation is similar to the technology. It's really similar to a GPS. It's a system that can localize something in the space. So we need the tracker on the patient, these 3 spheres. We need the camera. It's a special camera that acquires the localization in the space of the 3 balls, spheres. And the camera communicates with software, and we can have a picture combined with CT scan during live surgery. I try to explain the workflow in order to communicate step by step what happened. First of all, we need to capture images, and we do it by CT scan or MRI. We create a map, so we create a 3D and multiplanar reconstruction of our body part. We create a trip plan, so we create a surgical planning. It's the same. We create a surgical plan. We want to do this. I want to cut in this point, and I try to create my plan. And I can navigate in my plan. I can navigate in, during my surgery. It's a real-time tracking, a real-time spatial information. Okay? It's not all, because it's possible, not with the technology in this moment, but I think that it's not so far, because it's possible to superimpose virtual and real reality. In this way, we are doing every day. You can navigate with your screen on the telephone in a street, and you can superimpose reality with virtual reality. And I think that we can do in the future also in surgery. Why not? It's not so far.
It's the near future.
Yeah. So, what we can do with surgical navigation technology, we can project the instrument position onto the preoperative imaging data. So I want to put a screw in one place, in a precise place. I can track instrument position during the surgery. I know where is my instrument. I can visualize and guide the angle and the depth of the tool's cut. It means a drill bit or a saw during the surgery. And I can also register and track bony anatomy for positioning and alignment of the implants. The human surgery background, I don't want to discuss about it, but they are using that in intracranial, spinal, knee, shoulder, and hip replacement, and I think every month more than before. And so I speak about our project is ongoing. Fascinated by this technology, I started to my interest, and I would like to test it in a total hip replacement. Why? Because we have a problem. We have the problem of cup positioning. So the opposing viewpoint from some surgeons is we don't need navigation for total hip replacement. Yeah, could be true. We don't need also manual, automatic system for drive a car. We can do in an old way, but now we need. Okay. This is a paper from Human Medicine 2024. Look at this. They tested the acetabular cup, they studied the acetabular cup positioning in total hip arthroplastic in 170 subjects. And the placing of the cup was considered accurate in 53%. It means 50% are perfect, 50% not. Is my experience. In my clinical experience, this is more or less. I don't want to go in deep how much is enough or not. It means in 50% is not perfect. It's enough to try something better for me. So what we want during the surgery for cup, we want 45 degrees of lateral opening angle, so lateral inclination or something like this, and 20 more or less degrees of retroversion. This is our target. And to obtain this, we have three systems that we combine together normally. Local anatomical landmarks, it means we know the acetabulum and we try to put our instrument, so the reamer, our cap, in the correct position in relation to the acetabulum. The second system is this surgical guide. This surgical guide helps you as a spatial reference in order to obtain 45 degrees and 15, 20 degrees. And fluoroscopy. We use fluoroscopy during the surgery to check the alignment. This could be your Massimo. Thank you, sorry. I forget your name, sorry. And we use fluoroscopy during the surgery to check the position of our instrument and of our implant. It means the first one is not perfect, the second one is not perfect, and we need a third check. Problem and limitation. Surgical guides, the position of the pelvis can change during the surgery, and so our guides are not perfect during the surgery. You can do a mistake, a spatial mistake. Local anatomical landmarks. Are you sure that you can find good landmarks in this hip? I'm not sure. I have a new problem. And in the other one, in this, we have a lot of arthrosis, osteophytes, and some anatomical landmarks are not so easy. Fluoroscopy, yeah, it's a good system, but there is a safety problem. If I do one hip for in 1 month, it's not a problem. If I do one hip each day, each single day could be a safety problem for me and for my staff. This is a paper from human medicine. If you have a patient with a deformity similar to this, performing a total hip replacement could be really technical demanding. But we have similar cases. This is a hip, not normal, absolutely not normal hip, and is a unique single surgery. We don't have experience for this. What about breed implication? I talked about it because when I do a total hip in a dog similar to this, in a border collie or in a skinny Labrador, I'm confident. I have less problem, but I know that when I have a Rottweiler or a fatty Labrador, I have more problem. And I read in deep some papers, and they have, in human medicine, they have the same problem for obese patients. In this paper, they found that obesity is a problem during total hip replacement, because in the overweight and obese groups, robotic-assisted total hip replacement demonstrates significantly greater accuracy in acetabular positioning. So what it means? That I don't want to compare my standard approach in these dogs. I want to compare my standard surgery or my standard total hip in this and in this type of patient with navigation. Because I know that in this dog I can do a good surgery, but I'm not sure in this. It's different. It's not the same surgery. So our work, the first step was testing the navigation system on bone models obtained by 3D printing from a patient with hip dysplasia. And then we tested, or we are testing the system in a clinical case of total hip replacement. I go quickly. This is the first step. We had some bone models, and we tested by reaming, by inserting the cap in the plastic bone model. The first step is to apply the patient tracker, and we decide to apply the tracker on the iliac wing with 2 pins in order to stabilize perfectly and to avoid movement of this tracker, and is not so close to the hip, so it's far, and it's not a problem for the surgeon. After this, we apply and we scan, and we want this. I repeat, 45 degrees and 25. So the first problem is, it's true, we need this. At the moment, we don't know, because I read this paper, 3-dimensional morphometry of the canine pelvis, implication for total hip replacement surgery, and I discovered that biometrics advice for this inclination and lateral opening, but if you read inside the paper, these are 27 dogs. And if you look, this dog has 35, not 45, 10 degrees less or 10 degrees different. Another one, version angle. This is 20, this is 34. It means we apply standard approach, standard degrees for different dogs. A greyhound is straight, is perfect. A dachshund is not straight, is not perfect. So I think that we could be necessary in the future change our approach. Could be necessary to decide the specific angle for implantation in a specific breed, in a specific dog. I don't know. Today, I don't know nothing about. So we can do this type of video-assisted CT surgery. This is a bone model, and I can see my instrument, the direction. I can read the angle. You see, 41, 42, and so on. I skip a little bit. And we can do the same for the femur, okay? After this, we did post-operative CT scan in order to validate subjectively the result. Now I show to you the first clinical navigated total hip replacement. Is a really chronic and not easy dog. This is the surgery setup, okay? So step by step, application, CT scan, and after CT scan, immediately discover that the pelvis in the positioning is not well positioned. You see, it's not perpendicular to the table. I tried to do it, but at the end it's not correct. And what we did, we modified virtually the position of the pelvis, not manually. So it means now the software knows that this is the correct position, but I didn't modify the position of the dog. I did it only virtually. So I started with, we start normally deepening the acetabulum with 10, 20 degrees, and we can do it looking at the screen. You see 12 degrees, it's a little bit too much technical for if you are not orthopedics. And then we move on reaming at 45 degrees of lateral opening. You see now 42, 43, And now I try to correct the retroversion until 20 some around. I can rim and I can impact at the end the cap at the same angle. Okay, this is the CT scan, postoperative CT scan of the first patient, and we measured the result. So we have a lateral opening at 47. The target was 45. 2 degrees doesn't matter for me. This is the retroversion, 33. I don't know, it's okay. Clinically is okay, but the problem is another one, that this is the X-ray. It's completely different. For me, is not perfect, is not retroverted enough. Is a normoverted, there is no retroversion. So I talked about, and I didn't find immediately the solution, but the problem is real this or is real this? Now, I think that is more real this, because the pelvis is not flat on the table. So we have a tilt, the pelvis is tilted, and so it's not a perfect projection. So we have a new problem now that we need to resolve. So my feeling is that it's very, very similar to other video-assisted procedure, similar to arthroscopy. It's necessary to work with your hand here, looking the screen, but it's not so complex. If you do arthroscopy or video-assisted surgery, it's really easy. It's necessary learning curve, obviously. And another, my feeling is essential to trust the system, because sometimes your feeling during the surgery is completely different, but is more precise the indication of the system, of the navigator, compared to your spatial feeling. And during the surgery, the system gave me confidence at the point that now I would like to use this system for each single total hip. Okay, I spent a little bit more time in this moment, but I think that it's only a problem of a learning curve and to create a workflow. Okay, I come back to 3D printed guides a little bit. Why? Because I explained that I don't love this system. And my thought is, but today are really necessary, or tomorrow will be necessary? I don't think so, because this is a paper from Human Medicine. You can plan an osteotomy in the spatial model in your bone. You can create a virtual guide, and you can decide angle of your cut, and you can have a virtual guide with the navigator. So is the future this? We need this. We don't need plastic guides today. It's old. It's an old system. We need virtual guide. I want to cut here with this angle, and I want a second cut in another point and with another angle, and I think that is not so complex for you. Okay? Thank you.
There's a question.
Yeah. Sì, sì, sì. Questo se me lo vuoi togliere. Ah, ok.
So first of all, thank you so much for the amazing session. So just a small question. So you mentioned that using a virtual robot or assistance can help a lot doing the surgery. How about using AI, for example? Because you mentioned that
Using, sorry?
AI, artificial intelligence.
Yeah.
So if I have, for example, an obese dog and a normal sized dog, I don't have to go through 120 cases to look at how can I actually do the operation or the procedure, giving the AI the decision to, for example, I'll just tell them that I have a 20 kilogram dog with a deformity, for example, and he's going to tell me what to do, but he's not going to do the procedure. He's just going to tell me or suggest a way to do the procedure.
Yeah, I have no experience with these systems, so I can't explain. I can answer. I'm sure that will be the future. I'm sure, but I have no experience. Sorry.
Because right now it's being used actually in human medicine to
diagnose.
And also what you mentioned for 3D models and virtual reality, it's actually being used right now. Where I've seen a lot of times that human doctors and veterinarians would get 3D scans and use virtual reality to do the operation in a virtual space and then go into the OT to actually do the procedure, especially laparoscopic surgeries.
Lascio rispondere. The boss. È spento forse? No.
So I think that AI can help a lot, especially in defining the planning. So probably AI can simplify the planning process. So automatically can suggest line cut or drilling direction or drilling pathway. But yes, my answer to your question is yes, in the future we'll have the planning process. But I think that navigation, it's fundamental. AI cannot substitute navigation, can support navigation and simplify the process for sure. Thank you.
I have a question for Professor Martini and also Dr. Kuka. We were discussing that it's not easy to operate and have the monitors away, but do you think it's feasible to have the VR goggles, to have the lens, in order to operate? Because I think the new generation are very familiar. We are not that much, but I think in the future you can have the goggles and you can, you can see the scans, you can see whatever the contrast rating that's going in the subarachnoid space. So you don't need the monitors.
I can tell that I was now at the International Dental Show, and I'm not a dentist, I'm not a dermatologist. I tried the Google glasses with all the planning. And at the first time I was able to put an implant on the patient. I was impressed with that. Okay, so we just using the Google glasses because all their tools were already there. So I just put the glasses, I could put left and right, pull the images, and it was just amazing that me, without any experience on the field, I was able to put it virtually, of course, the implant on the right place. So yeah, it could help the Google glasses. Yeah.
I think that the Googles will help us a lot, because when we were discussing about ultrasound reports, like you can use the VR, you can put like the Googles, and while you're doing the ultrasound, you can report it also. So you can do like this, and the report is done whenever you finish your ultrasound. And we have to take our minds thinking, not our generation, because we think that also you can see a kid that has a VR goggles and say, it seems stupid for you, but it's not, it's the future. So for us, yeah, we're a generation that is not polite to go in the examination room and you see the doctor with the goggles and take an exam of your dog and he doesn't look at you, but he's reporting. And this is weird, but I think it's the future that we cannot avoid.